Thank you, and thanks to Turning Point for having me here. It's lovely to provide a general practice voice. We've had two such informative speakers so far. So I've been asked to speak about the challenges we face in general practice and what leads to aberrant prescribing. From the talk so far, we can tell that general practice is actually sort of seen as where most of the mischief is being made. For whatever reason, well, probably based on the numbers of GPs, and most patients present to general practices. Most of the prescribing, most of the aberrant prescribing is done in general practice. The lazy thinking, and I think sometimes the bias that we hold in medicine is that general practitioners are second-rate doctors. I won't ask for a show of hands as to who harbours that opinion. But I think that really flies in the face of the experiences that I've had both in hospital years and in general practice. Some of the best doctors I've worked with have been in general practice. And that's not to say that there's not a spectrum of competency. But sometimes those very good doctors also do things that make me scratch my head and wonder where that prescribing behaviour came from. I'd say myself, perhaps, I've been guilty at times of prescribing and later reflecting on it, thinking that probably wasn't the right thing to do. So I think when we look at the issue of general practice, we can't just say these are doctors that need more education, because GPs are very educated, we go through a lot of training. I think instead we need to look at what are the other factors that are pressuring, that are influencing doctors' prescribing. So that's what I'm trying to do today. It has the potential just to devolve into a rant, and I'm mindful that I would like to work again after this presentation. So what this is largely based on has been our experiences with opioids. To an extent, benzos and gabapentinoids, antipsychotics as well. I do a bit of training with the College of General Practitioners, training other doctors to prescribe methadone and Suboxone, and so some of the reflections have come from that as well. So when we're looking at the statistics and we're aware that opioids have been a problem, and I guess looming in the future is the medicinal cannabis and the way that gets prescribed. I think if we don't have a good understanding of how general practice operates, we kind of miss the opportunity to intervene early. And certainly what we've seen with the opioid situation is that our response has been very reactive to that, which is always really hard. I think in doctors you have your practice, you're ingrained in a fairly early stage. And so I think to then later on in a career change the way you work is very difficult and expensive and laborious. Now this is just sort of a 10 or 15 minute whirlwind of common sense. It's devoid of all evidence. It is just anecdotal stuff that sitting with friends and colleagues, having a cup of coffee, saying, what do you think is influencing you in prescribing in a manner that's not the way that you wish to? Just out of interest, how many people in the room have worked in general practice as a general practitioner? And so we've got a few. Excellent. Not many. So if it was a room full of GPs, this would be absolutely mind-numbingly boring. But it's interesting that people who are quite often involved in policy making don't have a great understanding of general practice. So I fairly haphazardly tried to group these, and sort of with the mindset that if we were trying to create a really competent, a very responsible prescribing doctor, how do we go about it? And it's not sort of intervening after the fact and changing the way they prescribe. So I've identified some of the challenges that we face in general practice, and those in the room who have worked in general practice will know these fairly well. So if we were to start at the beginning, I can remember a number of lectures we had on pain. And so this was 15 odd years ago, going through university, and having a series of lectures on pain. And the message I really distinctly remember a lecturer saying, if you have a patient and they're still in pain, you are not doing a good job. And so it's fairly explainable why now we're having people prescribing in the way they are. I mean, this has been our education so far. I cannot remember a lecture on addiction. Not that I remember every lecture I attended, but I think there was one patient-based learning case of alcoholism, early on, and that was really just to get us used to the format of it more than anything else. So we really had no training at the undergraduate level on addiction, and a lot on pain with the message that we needed to prescribe. Similarly with our consulting skills, we're really working to a model of meeting the patient's agenda, working with them collaboratively to meet their health outcomes. And that's all really nice. But when you're seeing patients who are using, well, who are taking prescribed opioids, and some might be somewhat attached to them, or taking illicit opioids, there needs to be more of a paternalistic bent to those consults, and we certainly don't get trained in that. The hard consults we had were, well, what we're trained to do was in how to tell someone they've got cancer. That was a difficult conversation. And we didn't have conversations around deprescribing. And I know, Kerry, you have experience now going around and talking to GPs about difficult conversations in general practice. And it is largely antithetical to what we've been trained to do so far. That way. Good. Moving into the general practice training program, we had a guy who I thought was the drug and alcohol guy, a tutor who gave us a few lectures. And it only dawned on me later that no, he was actually trying to teach us how to get patients with substance use disorders out of our room. That was his goal. It wasn't about engaging patients in treatment. It wasn't about taking an approach of identifying patients that need care. It was about getting them out of your room to lessen your medico-legal risk. I hope that's changed now. I know that Paul Grinzy is very involved in general practice training, so I do hope that's changed. The other aspect is that methadone training, or MATOD training now, sorry, has stood aside. It's been quarantined as a part of training. You don't have to have any interest in this. And it's seen as something you can do if you've got the interest. But if you don't have the interest, you don't need to think about it. Which I think general practice is a really hard area to study. It's a really hard exam to prepare for because there's so much that you might need to know. You can go into an exam fairly confident that you don't need to know much about addiction. There are very few questions on the exams, and I don't think there's ever been an OSCE station. It would take one little OSCE station, and for the next decade, people would be well versed on opioid use disorders. It'd be interesting if methadone, the MATOD training program, was actually made a essential part of the training program to see how that affects people's prescribing. Not so much that people may not increase the number of people who get into this sort of work, but it may create an awareness as to the problems we're having with prescription opioids. The other problem we have with training and education is that general practice is really hard because if you're going to stay abreast of all the research, all the emerging evidence in all the fields, it's an impossible task. But thankfully, most fields will take the information they've got and present it as a guideline, which is quite accessible. The difficulties we have in general practice is guidelines that are just not applicable to the real world. There are any number of examples where we struggle with this. Chronic pain in really complex patients with referrals to pain clinics. There almost needs to be a guideline for the 18 months that you have to spend waiting for a pain clinic appointment. 291 assessments for psychiatry, exceedingly difficult to get for patients on low incomes who aren't able to pay for it. Case management in the community. There's lots of things that really work against us. If we move on to how the workplace is structured, gone are the days where you had the single GP clinic and the GP working long hours doing everything by themselves. But I think general practice is still pretty entrenched in that model, in that you don't really share patient care very well. You certainly, it's not a culture that really lends itself to discussing difficult problems. As a result, you kind of get bogged down in what you've been doing and you continue to do it. And there really aren't the systems there to address difficult patients, difficult problems with peers. Thankfully, something that hopefully is going to change that is the general practice clinical advisory service that's being run through Turning Point. So this is out of SafeScript, knowing that GPs now will be checking SafeScript and potentially identifying patients who are at risk and reflecting on their own practice and wanting to speak to someone for advice. So it's a phone service where you call, a GP can call, and we'll have their call returned in a day or two to discuss difficult problems with patients. So far, the uptake hasn't been huge. I put an example up here of a call to the GP CAS. So a 49-year-old labourer who has been on long-term oxycodone for back pain, started by another doctor. Also on diazepam, but only getting a script of 50 every 2 to 3 months, so that the GP wasn't too concerned about that being problematic. On dexamphetamine, and the GP spoke to the psychiatrist before his last assessment, and they both thought that he probably doesn't have ADHD, and the psychiatrist said that he was going to tell the patient that and stop prescribing, but the letter still came back from the psychiatrist saying, I probably don't think he has ADHD, but I will support his prescribing. So it's always nice to be supported in general practice. Some escitalopram and some Seroquel was on his list, but he hadn't had a script for quite some time. He'd been injured at work and had a 10-week history of shoulder pain. And he had sort of forced his way into getting Oxynorm from the doctor. He was getting quite agitated when he was being challenged on this, and was giving a lot of manipulative language, saying to the doctor, if you don't give me this, I cannot continue to work. If I don't work, I can't pay my bills, and my life's going to be ruined. I'm not necessarily here to offer answers to that, or I can speak to the gentleman on the phone. I just think it's a really good example of some of the challenges in general practice. That's a fairly, on paper, it's probably an easy one to answer in an exam sense, but to sit in a room with the gentleman and actually talk him through his care and why he shouldn't be on a short-acting opioid for acute pain that's now becoming chronic pain on a background of chronic pain with opioid analgesia. They're difficult cases. So the calls that we're getting to GP CAS at this stage are very sensible questions from very sensible doctors. So hopefully over time, when SafeScript becomes mandatory next year, we'll get a bit of an uptake of the service. I've thrown in a little quiz here. I'm getting to the dirty bit where we talk about money. Would anyone hazard a guess at what the rebate is for a 6-minute consult in general practice?
VR or not VR?
VR. 38, yeah. Now, the 6-minute, the 5-minute is not actually in the descriptor for the item number, but yeah, most GPs would charge item 23, which would be $38.20. If we lengthen that out to an 18-minute consult, what's the rebate? Same. Oh, goodness, all right. And what is the rebate for the time that you spend on the phones to caseworkers, counsellors, legal representatives, corrections? That one speaks for itself, doesn't it? What I'm getting at here, though, is that general practitioners are really small businesses. They're almost universally not salaried. And if you're a practice manager running a clinic and you can get a GP seeing 8 patients for 6 minutes per hour, charging $38.20 times 8, or have a doctor seeing 3 patients for 18 minutes each hour, it's more than double the money. So the system isn't really designed for us to take our time and provide high quality care. Now, I'm not suggesting anyone in the room has the capacity to change that, and if you do, I'd like to speak to you. I'll very briefly touch on this. It's always threatened, it's always loomed, but you never see too much of it. As the corporates get into general practice, they talk about this shift towards clinic loyalty versus doctor loyalty. So the clinics don't want patients seeing the same doctor each time, because then you'll be loyal to the doctor, and if the doctor moves, you'll lose all your patients. So they want you just to walk in, see any doctor, and be loyal to the clinic. I think that has lots of problems. I think that really leads to poor continuity of care, and doctors don't take ownership of the problem, and then I think there's got that sort of prescribing inertia. Once something has been done that is fairly poor, it continues. I know there are people from the department in the room, so I won't say too much, but quite often the rules and regulations hold us back from doing what we think might be the right thing as well. OxyContin in general practice is easier to prescribe than a reasonable dose of Suboxone, Is that strange? Yeah, I think it's strange. And that's a real problem we have when we're running the MATOD training program, is that doctors are scared of Suboxone, they're scared of buprenorphine, because it seems hard, it seems dangerous. It's associated with methadone, it's guilty by association. You've got to get a permit before you give a script. You've got to organise pharmacy and photos, and then you've got to try and sell to the patient that they actually have to go to the pharmacy every day for the first 2 weeks. And it's going to cost them probably a lot more, depending on their healthcare card status. So potentially looking at general practice, if we had Suboxone more readily available to prescribe without the restrictions, I wonder what effect that would have. I mean, it's almost like we need a different classification of patients who are chronic pain patients, who may be opioid dependent from their other medications, who actually run through a different set of rules. SafeScript's about to kick in and become mandatory, and this has already been alluded to, that it comes up as a traffic light, sort of, a red, amber, green. And most GPs will use that opportunity of seeing a red light to say, computer says no, I can't do this. And patients will be fairly rapidly ceased off their prescription opioids. I'm also interested in what the patient response to this is going to be. I was talking to a gentleman in his experiences on doctor shopping for benzodiazepines. And he explained that if he thought the doctor was hopeless, he would try and get Xanax out of them. If he thought the doctor was pretty good, he'd try and get diazepam. And if he thought the doctor was really good, he'd just ask for Lyrica. And that was his hierarchy. I think as a profession, we don't discuss the risks and the changes very, very quickly. We don't have a very good system for that. I'll just very briefly go through these. We often get forced into doing things that we don't like to do because we are running small businesses. We are at the mercy of Google reviews. So we need to provide care that patients perceive as being of a high level, not necessarily evidence-based. Imaging for back pain has been a good example. Patients think that that's better care than not imaging. We've already touched on discharge targets and the management of post-operative pain today, so I won't go greatly into that, but that's one of those things that I guess as that gets tightened up from a hospital sense, sometimes that then falls down to a general practice sense, and it's something that we haven't necessarily been trained in very well, and it's a really difficult area of medicine to manage. The hospitals are really happy their discharge targets are met, but you've got patients in the community who often have opioids and then have pain that potentially needed to be treated as an inpatient. I was going to discuss a case study here, but I'm out of time. But the communication with the hospitals is another aspect that is done really poorly in general practice. I know my practice greatly improved when I got the mobile number of the addiction medicine registrar at my local hospital. It improved patient care significantly. Out of interest, how long do you think it would take for a discharge summary to arrive for a patient after they've been discharged? Weeks? We're getting weeks over there? Yeah. I asked my wife this and she said never, which is probably closer to the mark. So that time's flown. That's as I said, it's a real whirlwind of just common sense. These are the pressures that apply to general practice. And I think if we're not taking those into account when we're looking at broader policy decisions, we're probably doing GPs a disservice. I've just put up a quote there from a GP friend. I'll leave it unattributed. But I kind of agree with it that it is a very difficult job, and I don't think the answer to everything is just educate GPs more. Thank you for your time.